Welcome back, dear students. Let us begin with learning the individual complications of suppurative otitis media. First and the most important on our list is mastoiditis. So we have acute mastoiditis as well as latent mastoiditis, of which acute mastoiditis is very important, and let us focus maximum on acute mastoiditis. What is acute mastoiditis? It is inflammation of the mucosal lining of the middle ear cleft along with the antrum and the mastoid air cell system. Plus, it is associated with destruction of the intercellular septae in the mastoid bone. You all know that we have air cells as well as we have septae dividing the mastoid bone. Now, these septae are also destroyed. How are they destroyed? Because of hyperemic decalcification that occurs in acute otitis media. So, the definition is pretty predictable. Mastoiditis, itis meaning inflammation of what? Mastoids. But you should remember that it is not just inflammation of the mastoids alone. It is inflammation of the mucosal lining of middle ear cleft along with mastoid air cells, mastoid antrum. Now, the term middle ear cleft itself includes the mastoid system also, but to be specific, we are writing it like this. Mastoid antrum and air cells are inflamed, plus there is destruction of the intercellular septae. This is acute mastoiditis. Now, the term mastoiditis is specifically used when the infection involves the bony walls of the mastoid air cell system. Involvement of the bony walls is very, very important. Now, let us look into the etiology of mastoiditis. It is usually a complication. It occurs along with or it follows an episode of middle ear infection. Acute suppurative otitis media is the primary cause. Now, when does ASOM become mastoiditis? We have already know the factors, predisposing factors for complications. One is a highly virulent organism or a lowered resistance in the host because of various factors, systemic diseases, poor nutrition, immunocompromised condition, all of them. And there is another thing that you have to remember. Acute mastoiditis is usually seen in the mastoids which have a well-developed air cell system. Well-developed air cell system will predispose to mastoiditis. And you also know that children and extremely elderly, old age people are more prone, and more so it is seen in children, I can say. Although extremes of age is a broader word, I can say children. Children are more cases of repeat. In children, we see more number of cases of mastoiditis. And what is the most common causative organism? It is beta hemolytic streptococcus. Beta hemolytic streptococcus. And certain other remote ways of mastoiditis are if there is a penetrating injury, a trauma, that can also lead to mastoiditis, and sometimes even bloodborne infections can lead to mastoiditis. So these are the various etiological factors. What is the most common organism? It is beta hemolytic streptococci, but please remember that anaerobic organisms are also associated with mastoiditis. Why you must remember this? Because while prescribing antibiotics, make sure that you have an anaerobic cover also. So this is about the etiology. Now let's look into the pathology. Now step by step, let us look what exactly is happening in acute mastoiditis. Now first, as you know, there is infection of the mastoid air cells. There is acute infection of mastoid air cells. Infection will lead to inflammatory changes. What are some of the inflammatory changes? There is persistent hyperemia, congestion of blood. Then we have edema of the mucous membranes. Classic changes of inflammation. Plus, there is osteitis, inflammation of the bone. All these things, the hyperemia, the edema, will lead to obstruction to the Otitis. What is Otitis? It is the communicating pathway channel between the middle ear and the mastoid antrum. Because of this engorgement, because of this edema, there is obstruction to the Otitis. When there is obstruction to the Otitis, the Otitis is obstructed, but the formation of pus inside the mastoid antrum continues. There is further formation of pus. So, purulent exudates accumulate in the antrum. So, pus is produced under high pressure. It is getting obstructed there and a tension is being built up. Now, there are natural openings for the drainage of pus. One is the tympanic membrane perforates and gives way. Through the eustachian tube also the pus travels, but the amount of purulent exudate that is being formed is so huge in quantity, these small openings with the obstructed Otitis are not allowing free passage of pus. This is leading to the accumulation of pus and building up of tension in the mastoid antrum. Now, because of the pressure effect, what happens is venous stasis occurs. Venous stasis will lead to local acidosis, isn't it? Now also, when there is venous stasis and local acidosis, calcium is being reabsorbed into the blood. From where is that calcium being formed? By decalcification. This is what is called as hyperemic decalcification. It is happening at this stage. There is absorption of calcium into the blood. What happens further on? When there is hyperemic decalcification, all the bony septa are being broken down. There is breakage of the intercellular septa. This is what we have seen here, right? Destruction of the intercellular septa is an important feature in mastoiditis. Now, when there is disruption of the intercellular septa, it can lead to the formation of abscess. Various types of abscesses can be formed. It will track down to the various cells, air cells. It can be a post-auricular abscess, it can be a zygomatic abscess, Wesol's abscess, Italy's abscess, apical abscess, Lux abscess, parapharyngeal, retropharyngeal, like this. Various types of abscesses can be formed depending upon the tract, the path of infection. I hope you have understood the pathogenesis of mastoiditis. First, what is happening? Infection spreads into the mastoid antrum, and then because of the inflammatory processes, the engorgement, the edema, and accumulation of the local inflammatory exudates, the Otitis becomes narrowed and all the pus is getting accumulated inside the antrum. The pressure builds up, leading to venous stasis and local acidosis, and decalcification also occurs parallelly. Because of all this, the bony septa, the thin bony septa in the mastoid, they're broken down, making this entire mastoid into a one single large irregular cavity that is filled with pus. This is classical mastoiditis. Then what happens? Even then it doesn't end. All this pus will further accumulate and then it will try to break open outside, leading to the formation of abscess. And there are various types of abscesses that are possible. Let us look into some of them one by one. First comes your post-auricular abscess, because this is the most commonly seen abscess. Post-auricular abscess. It is most commonly seen. And where exactly is the pus collected here? Beneath the periosteum, behind the pinna. You can see it behind the pinna. Post-auricular, behind the auricle. So when there is a post-auricular abscess, what happens to the pinna? There is an abscess here. This will push the pinna forward and outward. The pinna is pushed forward and outwards. And you can see that there is a fluctuant mass that can be palpated behind the ear. You can see it as a swelling. This is your post-auricular abscess. Second is Bezold's abscess. What is this Bezold's abscess? When the mastoid process has a tip, right? When there is perforation and necrosis in that tip and the abscess breaks out, the pus breaks out via the tip and collects in the anterior border of sternocleidomastoid, then we call it Bezold's abscess. What you must remember here? Mastoid tip is important. And where is the pus collecting exactly? Under the anterior border of the sternocleidomastoid. Now this very same Bezold's abscess, if it extends further along into the digastric, into the submandibular triangle, then we call it Citili's abscess. If extends along the digastric muscle, into submandibular triangle, then it is called as Citili's abscess. Next we have zygomatic abscess. This comes anteriorly. This is the zygomatic process, right? So when the swelling is here, it will cause facial swelling. Even the eyelid shows swelling. See, abscesses are very simple if you have a basic understanding of the anatomy of head and neck, right? I'm assuming you know where is the zygomatic process, you know where is the sternocleidomastoid muscle, where is the digomastric, where is the digastric muscle, and so on, right? Okay. So zygomatic abscess, it is anterior and it causes facial swelling. Then we have something called as the apical abscess. What is about this? Now this abscess extends up to the petrous apex. It extends up to petrous apex. And what is the very famous sign that you see in petrositis? Gradanego syndrome. It produces Gradanego syndrome. How does the Gradanego syndrome present as? There is ear discharge and the fifth and the sixth nerves are also involved. So you have deafness, there is cervicofacial pain, diplopia and all of that. Next, after the apical abscess, we have pharyngeal abscess. I told you parapharyngeal abscesses, retropharyngeal abscesses, they all occur when the pus spreads via the peritubal cells along the eustachian tube. From the middle ear, via the eustachian tube, it comes anteriorly and then it affects the pharynx and causes pharyngeal abscesses. So what must you remember here? That it is spreading via the peritubal cells of eustachian tube. And then we have something called as Lux abscess. This is in the infratemporal region. The abscess is between the temporalis muscle and the temporal bone. So when the pus trickles down from these cells, you can see that it opens into the external auditory canal. Where in the external auditory canal? In the posterior-superior bony meatal wall. So what must you remember here? That it is between the temporalis muscle and temporal bone. And how is it communicating to the exterior? Into the external auditory canal. Via the external auditory canal, the pus comes out. So these are the various abscesses that are formed in continuation to mastoiditis. Now let us look into the clinical features of mastoiditis. The various signs and symptoms. Coming to symptoms first. We have pain behind the ear. This statement, pain behind ear, is most important in mastoiditis. Because in acute mastoiditis, there is in general generalized ear pain. And now please remember the symptomatology of otitis media and mastoiditis will more or less be same. Then how will you get a clinical suspicion that the patient is in mastoiditis? Based on the progression of symptoms. In acute otitis media also there will be pain, but once you give antibiotics, the pain will subside. Or once the tympanic membrane perforates, there is a feeling of giving away and the pus starts to come out, then also the pain subsides. But if it is continuing, if the pain continues even after tympanic membrane perforation or even after prescription of antibiotics, that means maybe the patient is in mastoiditis. The pain persists, or sometimes it can even increase in intensity, or there is recurrence of pain, then you have to understand that it is going into mastoiditis. See, that is the reason we say it's important for the same doctor to see the same patient again and again. Because the patient has come to you with ASOM, you have given antibiotics and the pain has subsided. 1 week later, if the same patient comes back to you with again the complaint of pain, you will get a suspicion because you have seen that patient and you know that he has been on antibiotics and still there is pain. Next, fever. Infective condition will lead to fever. Again, same like pain. When there is persistence of fever or recurrence of fever, in spite of adequate antibiotic treatment, think of mastoiditis. And then we have discharge from the ear. Ear discharge is seen in ASOM and CSOM also. In ASOM, after the rupture of tympanic membrane, you see ear discharge, and in recurrent episodes in CSOM also, we see that there is discharge. But in mastoiditis, the discharge is very profuse discharge, and there is increase in purulence. Purulent, profuse discharge. And in case the discharge suddenly stops, is it a good thing or a bad thing? We think generally, logically, that the infection has subsided, so the discharge has stopped. But please remember that there is another possibility that there has been an obstruction to the discharge, and that is why you are not able to see the discharge outside. Inside, back then, it is worsening further. There are complications that are occurring. Same thing I told you with cholesteatoma also. If the symptoms suddenly stop, suspect an obstruction. It is not exactly healing or recovery. Maybe there is an obstruction and the pus is building up inside. So, if the discharge persists beyond 3 weeks, generally think of mastoiditis. It has to be profuse and purulent, and if it's more than 3 weeks, think of mastoiditis. What are the signs? Number 1, there is mastoid tenderness. If you press upon here, there is tenderness, and this is a very, very important sign. So, tenderness is elicited by pressing on the center of the mastoid process or at the tip of the mastoid process or even at the root of zygoma. Now, the tenderness that is elicited over the suprameatal triangle, it could be mastoiditis, it could not be mastoiditis, because even in cases of acute otitis media, because of the inflammation of mastoid antrum alone, that is, there is no bony destruction of septum and all those things, just antritis is there. There also you can find tenderness in that area. So it's not exactly diagnostic of acute mastoiditis, but always look for mastoid area tenderness. Then ear discharge, you will observe. How is the ear discharge? Profuse and purulent. Plus there is a very important sign here, pulsatile discharge. There is pulsatile ear discharge, and this pulsatile ear discharge is called as the lighthouse sign. You all know what a lighthouse is, right? In the middle of the ocean, we have lighthouse that keeps on blinking. It shows the direction to the people traveling in the sea. This also, it's that blinking kind of discharge, pulsatile discharge, because of mastoiditis. That's coming out via the perforation in the pars tensa. Then the posterior-superior meatal wall sags down. This is important. Sagging of posterior-superior wall of external auditory canal. Why is there sagging? Because periostitis of the bony part. In the external auditory canal also, it is the bony part that sags down because of periostitis between the antrum and between the deeper part of the bony canal. These are the signs that you see, and apart from that, of course, there will be perforation of tympanic membrane. And this perforation can sometimes look like a nipple-like protrusion. A small perforation in pars tensa will be there, and that because of the discharge that's constantly coming out of that perforation, you can see it like a nipple-like protrusion is seen. Sometimes it's possible that Sometimes it's possible that the tympanic membrane is not perforated, it is intact, but you can see that it looks dull and opaque. When does this occur? When a sufficient amount of antibiotics are repeat. When does this occur? When the patient has been partially treated. The infection has been controlled to some extent, so that is why there is no perforation of tympanic membrane and drainage of pus. But it is not completely controlled, there is inadequate usage. That is the reason some amount of pus is still remaining inside. So the tympanic membrane looks